Hello, my name is Lwin, a clinical research fellow from King's College London in the UK. So it is my honour to present this poster on behalf of GENEGRAFT partners. GENEGRAFT is a European Union funded project as part of the 7th framework programme involving 4 partners coordinated by Professor Alain Hovnanian from INSERM in France. And the other partners include King's College London in the UK, Madrid, Spain, and FERT in Germany. So this poster is about how we carefully selected the patients who will be optimal for ex vivo autologous gene therapy for this phase 1/2 first-in-man clinical trial using gene-corrected skin equivalents. So a bit of background on the disease itself. So recessive dystrophic epidermolysis bullosa is one of the most severe inherited skin fragility disorders caused by loss of function mutations in COL7A1 gene. This particular gene encodes type 7 collagen protein that is the main constituent of anchoring fibrils that ensures dermal epidermal adherence. So in individuals with RDEB, they suffer from lifelong pain. They endure lifelong pain as a result of skin and mucosal blisters and erosions. And ultimately, they develop cutaneous squamous cell carcinoma, usually by early adulthood. So currently, there is no cure for this devastating disease with high morbidity and mortality. So this is the very aim of GENEGRAFT project, to develop a safe and effective gene therapy for individuals with RDEB. So in order to do that, we would start with the phase 1/2 clinical trial. All the preclinical work has been done by various colleagues and partners all within those 4 countries for several years. So now I just want to illustrate what is involved in the phase 1/2 gene therapy trial for GENEGRAFT. So figure 1, you can see that skin biopsy is obtained from an adult with RDEB, and then the biopsy will then be shipped from France to Madrid in Spain to extract the keratinocytes from the epidermis and fibroblasts from the dermis. They would then be cultured in the GMP lab. They would then be transduced using a viral vector, the self-inactivating retroviral vector encoding full-length COL7A1 cDNA. So this particular viral vector should be safe since it is not the classical retroviral vector and it is self-inactivating. So once the transduced cells are expanded, a skin equivalent would then be generated to graft approximately 300 centimeters squared of chronic EB wounds in adults with RDEB. So when we are selecting the patients for such therapy, one has to consider the risks. And in order to minimize the risk of these individuals potentially developing autoimmunity against the new type 7 collagen that they would express after receiving the gene therapy, we have defined several patient selection criteria. But in particular, I just want to draw your attention to the fact that we will be choosing moderate to severe form of RDEB. And also they need to have low level of type 7 collagen expression in their skin. And also they should have negative indirect immunofluorescence, meaning that even if they have circulating autoantibodies, they should not be binding to the basement membrane to cause an autoimmune form of EB, such as EB acquisitor. So having defined this criteria, we then identified 30 patients, 21 from France, from Necker Hospital in France, and 9 from Guy's and St Thomas hospitals in the UK. So of which, having gone through the patient characteristics, we then excluded 22 patients. So we're now left with 8 optimal patients, 6 from France and 2 from the UK. So, of course, in the interest of time, I just want to summarize the table here. So, of 8 patients, the age ranged from 18 to 48 years, and 4 males and 4 females, and they all have negative indirect immunofluorescence and no history of squamous cell carcinoma. And the other thing to point out is that everybody except patient number 3 had positive NC1 domain, so that's the non-collagenous domain 1 antibody on immunofluorescence. So we've now identified these patients. Just wanted to show you very briefly all these 8 patient clinical pictures. You can see patient 1 and 2, they have quite severe phenotypes. And then there's patient 3 and 4, patients 5 and 6, and then patients 7 and 8. So now that we have defined these patients, 3 would then be nominated to receive the gene graft, and currently the gene graft clinical trial is undergoing trial applications and approvals. So just to give the future vision of gene graft, I would like to invite Professor Alain Hovnanian. Thank you.
I'm Dr. Alain Hovnanian. I'm a geneticist working at Necker Hospital at the Imagine Institute in Paris. And as Dr. Lwin has explained, gene graft aims at using gene-corrected skin equivalent to treat chronic wounds in a small number of patients affected with recessive dystrophic EB. So why are we using so-called skin equivalent instead of a simple epithelial sheet? There are 2 main reasons for this. Correcting both cell types, which is what we do when we correct both keratinocytes and fibroblasts, allow us to restore not only dermal-epidermal junction in order to prevent blistering and erosions, but also it will normalize or regulate the dermis and prevent aggravation of fibrosis, which unfortunately is constant in these severe forms of the disease. This first-in-man trial, in fact, will be the first wave of different clinical trials, and very soon we hope to offer this type of treatment to children, as well as we hope to be able to graft more challenging areas like flexures, like fingers and hands, and in order to provide a better benefit to the patients, and in order to show that quite large areas of the body can be treated in order to provide a long-term correction of the treated areas.